my name's Tom and I'm a physio from Before Physio Pilates in Ivanhoe, and today I'm joined by Dr. James Taylor, who's a sports doctor at the Australian Sports Doctors. So we work pretty closely with James with a number of our patients who just need that next step of medical assessment and intervention, and today we're here just to discuss hip osteoarthritis. So firstly, James, how do you go about diagnosing someone with hip osteoarthritis?
Thanks for having me in today, Tom. We go about diagnosing someone with osteoarthritis of the hip predominantly on history. So we ask people about the location and nature of their pain. Often with hip osteoarthritis, there is pain in the front and the rear of the hip. Sometimes it runs down the thigh or into the knee. So it can also be just components of that and can be mistaken for back pain or gluteal pain. So we have to spend a lot of time on history to try and understand not only the location of the pain, but the duration of the pain, the triggers for the pain, and from that we can formulate an appropriate examination to look at the way that people walk, to see what restrictions they have on their movement when they try and use their hip. And we do bend the hip into certain specific directions to look for how far the hip can move and how comfortably it can move through those positions. From there, we also use some basic confirmatory investigations. The predominant one for those is hip x-ray, although sometimes we might also use an ultrasound or MRI to look at other specific features.
And if someone isn't a candidate for surgery, what are the best treatment options there?
That's a great question, Tom, because hip replacement surgery overall has a slightly broader application and perhaps at a younger age than knee replacement surgery does. Of course, that is highly individualised. But if someone ultimately isn't ready for hip replacement surgery, or if they are not suitable for any kind of major surgery, we can look to both the combination of physical exercise and weight loss as the main evidence-based treatments for improving mobility and management of pain, as well as some psychological interventions, oral analgesia, and occasionally injections into structures around the hip to help alleviate some of the secondary causes of pain around the bursa and the gluteal tendons. Occasionally we also use intra-articular injections to settle down flares with cortisone. Less commonly, but sometimes we will use lubricant injections and platelet-rich plasma injections, although the evidence base for that in hip arthritis is less so than it is for knee arthritis. Tom, is it expected that patients will experience discomfort or some level of pain during exercise?
Yes, so it's a good question. We do know with all the evidence behind osteoarthritis treatment that it is safe to feel pain during exercise as long as it is at an acceptable level. So that acceptable level is different for everyone, but generally we're trying to get pain that it's 4 to 5 out of 10 or lower, and it settles to your normal levels of pain within 24 hours. So that's where having a physio that will keep a close eye on you in your exercise sessions is so important, that we can make sure you're tolerating exercise as we would like. But if we find you aren't tolerating as we would like, you're just hitting a bit of a plateau, or pain's becoming a really limiting factor, that's when we often might send a patient down to our sports doctors like yourself, James, to see whether further medical assessment or intervention may be needed. And that's where I'd like to ask you, James, what are the sort of traits or characteristics that you think an injection may be necessary for a patient?
It's a great question. I think we really like patients to give a decent trial of physical therapy for the evidence-based period of time before we start to consider injections. Now, there are some exceptions to that, but generally around about the 6 to 12 week mark, if someone's not making the progress that you or they would hope or expect based on the evidence for that program, then we can look at whether we need to use injections to see if they can assist breaking through a plateau period or whether they can help to accelerate somebody's progress. Now, it's a little bit different than the knee. The level of evidence for the injections for hip conditions is a little bit different than the knee. So we need to be a bit mindful of that evidence base, particularly in relation to the hip as well as the knee. But there are some steroid injections and some platelet-rich plasma injections that do have a role in structures around the hip, which can ease pain for secondary conditions, and also some intra-articular injections, including gels and PRP, that can be considered in difficult cases where things aren't going according to your hopes or the patient's hopes and expectations. So Tom, what kind of benefits do you expect to see clinically for someone with hip osteoarthritis when they engage in a supervised and progressed exercise loading program?
So we often see people are quite surprised by the amount of exercise they can actually do. So often people have been fearful and avoided certain exercise for many years. And when we actually break it down into safe and sort of controlled manner, they're surprised at what they can actually do within their hip. And then as we go through, their confidence within their joint really improves and they're happy to increase the difficulty of exercises. And with that, as their confidence improves, they find previous issues they've had in their life, such as they've had difficulty going downstairs or walking for long periods, they're just not as much of a challenge and not much of an impediment on their daily life anymore, which is really good to see. And then with that, they just have a better understanding of how they can manage their condition and can take control of their hip joint.
And what can participants expect when they first enter this progressive exercise loading program?
In the first stage of their program, we take patient history, we perform some strength measures, and just look to see what they can and can't do functionally before we start to build the foundation of their program. So this will be some one-on-one appointments where we will look at making the basis of that program with your physio, and from there we can progress to a small class setting. So this small class setting is a maximum of 4 people where there's always one physio supervising to make sure you're performing your exercise appropriately and that you're tolerating them as we would hope. So you're not expected to know your program off by heart as you begin the program.
So Tom, I know that at different stages of the program, you measure the strength of the hip and knee at the start and at different intervals to check, I assume, progress. Why is it that you do that? And what can you expect to see during the course of the program?
So we take our patients' strength measures ongoing with the program, just so we can see what level of function they're at the moment, and that helps us design our program so it's appropriate to their level. I think we also do it to make sure we're including all the muscle areas that need to be included to make sure it's a comprehensive strengthening program. And we generally see that those strength measures should go up towards the second half of the program where we're getting to a more difficult and sort of strength-based exercises. But even before that, we can usually see quicker improvements in terms of control of the hip, as well as improvements in questionnaires where patients will rate their pain and quality of life.
And at the end of the program, what is it that patients and yourself expect to see? And what is it that they can do next? What are the next steps?
At the end of the program, patients can expect to have a much better understanding of their condition and what they need to do to manage it going forward. We generally see pain levels will decrease, but patients should be able to understand their pain better and understand what they need to do to manage their pain levels. Ultimately, we know that osteoarthritis is a lifelong condition, so it needs to be addressed accordingly. So that means we're going to have to keep some level of ongoing strength maintenance. So that's where we have the option of progressing to a maintenance program, or for those wanting to get to more higher levels of function, such as running or jumping activities, we have the option of progressing to an advanced program. But ultimately, the bottom line is to maintain your joint health, you're going to have to keep some level of appropriate loading to keep a healthy joint.